Assalamu alaikum. I am Dr. Marji Akon, registered Gynae and Obstetric Department, CBMCB. Honorable Vice Principal Sir, Professor, teachers, my dear senior and junior colleagues, my beloved intern doctors, welcome all of you to this weekly clinical presentation, a case of Puerperal Pyrexia. Today's seminar will be chaired by Professor Dr. Sheila Sen Ma'am, Professor and Head of Department CBMCB, Gynae and Obstetric Department CBMCB. Today's speaker, Dr. Nafisa Sultana Shathi, Assistant Registrar, OBG Unit 1. Today's seminar arranged by Gynae and Obstetric Department Unit 1. Now, I am requesting Honorable Chairperson Professor Dr. Sheila Sen Ma'am come up to the dais and conduct rest of the session.
Thank you, Dr. Marjia. Very good morning. I welcome you, respected Vice Principal Sir, my senior colleagues, senior and junior colleagues, my intern, beloved interns. I welcome you to this today's clinical meeting will be on Puerperal Pyrexia. Today's speaker is Dr. Nafisa Sultana Shathi. Now I am inviting Dr. Nafisa to deliver her speech. She is very known to all, so there is no need to introduce her. Thank you.
Honorable Chairperson, respected teachers, and my dear senior and junior colleagues, Assalamu alaikum. Welcome you all to this clinical meeting. With kind permission of my chair, I, Dr. Nafisa Sultana Shathi, would like to present this case. Mrs. Ruma, 35 years old, Muslim housewife, hailing from Trishal, Mymensingh, admitted in this hospital 12th July 2024 at 7 p.m. and we examined her same date at 7:15 p.m. Presenting complaints: history of delivery by cesarean section 10 days back, abdominal distension with respiratory distress for 2 days, fever with abdominal pain for 5 days, foul smelling per vaginal discharge same duration. History of present illness. According to the statement of the patient, she underwent cesarean section 10 days back in a private clinic. She was discharged on 4th day of puerperium. On 5th day, she developed high fever, which was continuous in nature, but no chills and rigor. She also complained of lower abdominal pain, which was dull, aching, and non-radiating. With these complaints, she went to that clinic and treated, but her condition was not improving. For last 2 days, she developed abdominal distension with respiratory distress. She had also foul smelling per vaginal discharge, which was blood stained. Her bowel was not moved for 3 days. With these complaints, she consulted with an obstetrician, and according to her advice, she got admitted in CBMCB for further management. History of past illness. No history of hypertension, diabetes mellitus, or thyroid disorder. Obstetric history. Married for 14 years. Para 5. 2 vaginal delivery and 3 cesarean section and 1 abortion. Age of the last child 10 days. Menstrual history. Age of the menarche at 13 years. Her menstrual cycle was regular. Her LMP was 2nd November 2023. Contraceptive history. She did not practice any contraceptive method. Personal history. She was non-smoker and non-alcoholic. Family history and drug history, nothing contributory. Immunization history. She was immunized as per EPI schedule and COVID-19 vaccine. Socioeconomic status, she belonged to low socioeconomic status. Physical examination. On general examination, patient was ill-looking, restless and non-cooperative. Body build average, weight 71 kg. She was moderately anemic. Jaundice and cyanosis absent. Edema 2 plus. Dehydration absent. Pulse 140 beat per minute. Blood pressure 80 by 60 millimeter of mercury. Temperature 102 degree Fahrenheit. Respiratory rate 40 breaths per minute. Partial pressure of oxygen 82%. Lymph node not palpable. Heart sound first and second heart sound audible. Lungs crepitations were present in both lungs. Per abdominal examination. On inspection, abdomen was distended, umbilicus everted. Transverse scar mark was present in lower abdomen, which was healthy. On palpation, abdomen was distended and tender. On percussion, tympanic. On auscultation, bowel sound was absent. Per vaginal examination, foul smelling, blood stains discharge was present. Respiratory system examination, respiratory rate 40 breaths per minute, no chest deformity or scar mark. Trachea centrally placed, on percussion, dull on basal area of both lungs. Auscultation, breath sound diminished in basal areas but crepes present in both lungs. Cardiovascular system examination, jugular venous pressure not raised. First and second heart sound audible in all auscultatory areas, no added sounds. Nervous system examination, patient was disoriented and non-cooperative. Other systemic examinations revealed no abnormality. Salient feature, Mrs. Ruma, 35 years old, Muslim housewife, para 5. 2 vaginal delivery and 3 cesarean section and 1 abortion. Hailing from Trishul, had cesarean section in a private clinic 10 days back. She was discharged on 4th day of puerperium. On 5th day, she developed high fever, which was continuous in nature, but no chills and rigor. She also complained of abdominal pain, which was dull, aching, and non-radiating. For the last 2 days, she developed abdominal distension with respiratory distress. She had also foul swelling per vaginal discharge, which was blood stained. Her bowel was not moved. On general examination, she was ill-looking, restless and disoriented. Pulse 140 beat per minute, blood pressure 80 by 60 millimeter of mercury, temperature 102 degree Fahrenheit and moderately anemic and edema 2 plus. On systemic examination, respiratory rate 40 breaths per minute. Crepitations were present in both lungs. On para-abdominal examination, abdomen was distended and tender. Bowel sound was absent. Per-vaginal examination revealed foul swelling, blood stain discharge. On systemic examinations, revealed no abnormality. Clinical diagnosis. 10th day of abnormal puerperium following cesarean section with puerperal pyrexia due to puerperal sepsis with septic shock. Investigations done 13th July. Hemoglobin percentage 8 gram per deciliter. WBC count 25,000 per cubic millimeter. Neutrophils 78% and lymphocytes 18%. Platelets 1,50,000 per cubic millimeter. Bleeding time 4 minutes 40 seconds. Clotting time 6 minutes 0 seconds. Prothrombin time patients 18 seconds. Index 67%. INR 1.63. D-dimer 7.21 microgram FEU per milliliter. CRP 149.3 milligram per liter. Blood grouping and RH typing A negative. Random blood sugar 6.5 millimole per liter. Serum bilirubin 0.5 milligram per deciliter. serum creatinine 0.08 milligram per deciliter, serum urea 41 milligram per deciliter, serum electrolytes within normal limit, serum SGPT 14 unit per liter, anti-proBNP 5555.2 picogram per milliliter, serum troponin I 0.03 nanogram per milliliter. Urine for RE, pass cell 2 to 3 per high power field, RBC 60 to 70 per high power field, chest X-ray, cloudiness in both lung fields, Carlis line, especially B lines visible. Ultrasonography of whole abdomen. Uterus is poorly outlined, having moderate endometrial collection with inhomogeneity of caesarean marked area and apparently a gap in caesarean wound. Moderate dense collection with peritoneal cavity. Suggested caesarean wound dehiscence with moderate dense intraperitoneal collection. These are the investigation profiles of this patient. Treatment. On admission and 7:30 p.m. Bed rest. Patient was kept on cardiac bed with monitoring. Diet nothing per oral. Oxygen inhalation 4 to 6 liter per minute. Infusion 5% DNS. Injection ceftriaxone. Injection gentamicin. Injection metronidazole. Injection PPI. Injection cortison and paracetamol suppository was given. All the antibiotics were started after taking with vaginal swab for culture sensitivity test. But patient's condition got worsened in OBG ward. So patient was shifted to ICU at 11:40 p.m. on the same day of admission. Treatment in ICU. Bed rest in propped up position. Oxygen inhalation 6 liter per minute. Nebulization. Infusion 5% DNS. Injection meropenem. Injection cortison. Paracetamol suppository. Injection furosemide and injection esomeprazole was given. After receiving ultrasonography report, decision was taken for laparotomy on 13th July. A bench was set for this case with the involvement of OBGYN, surgery, anesthesia, ICU departments, and collective decision was taken in favor of laparotomy. Laparotomy was done under general anesthesia. Findings of laparotomy. Uterus was about 16 weeks size, soft in consistency, covered with omentum. There was pseudo-adhesions between uterus and gut. Peritoneal cavity filled with hazy fluid. Multiple loculi was found between the gut, paracolic gutter and subhepatic space, filled with fluid which was found smelling. Ediciolysis was done and fluid was drained. Thereafter, subtotal hysterectomy was done and there was small amount of placental tissue and collected blood, clotted blood within uterine cavity. Before closing the abdomen, peritoneal toileting was done by normal saline and 3 drain tubes were given in right paracolic gutter, pouch of Douglas and subrectal space respectively. Operation was done by senior obstetrician, surgeon and anesthetist. Immediately after operation, patient was shifted from OT to ICU. All the post-operative management and monitoring was given there. 4 units blood were transfused, 2 units per-operatively and 2 units post-operatively. Last unit blood was given at 2 p.m. on 15th July. She was on ventilation for 2 days following laparotomy. Extubation was done at 11 a.m. on 15th July. Her condition was stable up to 2 p.m. Thereafter, all her vital parameters got rapidly worsened following transfusion of 4th bag of blood. She took her last breath on 15th July at 9 p.m. despite all the efforts. Take-home message. Family size should be limited by proper use of contraceptives, regular antenatal checkup, and birth planning in each pregnancy. Placental localization should be done by ultrasonography to exclude placenta previa, accreta, and increta following previous cesarean section in every pregnancy. Third and above cesarean section should be done in tertiary care center by senior obstetrician and anesthesiologist, and donors should be ready. Strict aseptic measures should be taken during preoperative, perioperative, and postoperative period. Blood transfusion should be rational and strictly monitored and vigilant to manage any complications. Thank you.